I think we are live now also on the YouTube channel, so that's great. And I'll close this. I'll close this. I'll leave this site. And we already have a, okay, chat is working okay. Participants, apologies, I'm trying to sort out a couple of things and we are nearly there. So it's good evening, everyone, and many thanks for joining us again. This is webinar number 75, and it's great to have so many people registered for this webinar. It's a non-technical webinar. It's about radiotherapy, which is very important for most people now. I can see that many people have started putting things on the chat function. Welcome, everyone. If you want to put where you're logging from, that will be great to see how many people we have online today. If you have any questions, please put them on the Q&A section. Don't put them on the chat function because otherwise they will be lost. And you will get all your CPD points and certificates after. Just give me about a week after the webinar. Now, we have a lovely lineup today. We have John Conibear from London. We have Fady Geara from Abu Dhabi. We have Susan Cleator from London and Icro Meattini from Florence giving talks. And we have the lovely MS Spurrell also from London. And we have Michalis Kontos from Athens in Greece. You have 4 channels for translation today. So we have the lovely Ricardo Pardo. If you want to listen to the talks in Spanish, please click on the Spanish language. If you want in English, of course, you stay in the English channel. We have Akram Girgis, who's going to do Arabic translation. Thank you, Akram. And thank you, Ricardo. We have Michalis Sorotos from Rome. He's going to do Italian. And we're trying to sort out Tatiana Zotina to do the Russian channel. We have some technical difficulties, but we will sort it out as soon as. We'll start with the talks. We have the first talk is by John Conibear, and John is going to talk about radiotherapy in general, radiotherapy and overview. John, the next 15-20 minutes are all yours.
Thank you ever so much. So let me share my screen. So hopefully you can all see that.
Perfect.
So, my name's John Conibear. I'm a clinical oncologist. I look after patients with breast cancer in Bart's Hospital in London. Thank you for inviting me this afternoon to come and share a talk, really giving an overview of radiotherapy and the management of breast cancer, in particular early breast cancer. So my disclosures this afternoon, I have no scientific conflicts of interest to declare based on what I'm going to talk about. In terms of today's talks, I'm going to start where we began, really, with early surgery, early radiotherapy, and then I'm going to take you through the science behind the advances we've seen demonstrated that's led us to where we are today. And then finally, I'm going to touch on some where the future is likely to land. So if we go back in time, it really began with William Halsted and the radical mastectomy, which didn't involve radiotherapy then, but it was obviously a very significant operation involving the removal of both breast lymph nodes, underlying muscle. And so this radical procedure really was quite intensive for the patients undergoing it. We've seen the use of brachytherapy in the management of breast cancer. This is a slide from Bart's showing patients having brachytherapy to treat tumors within the breast. You can also see where those little brachytherapy needles have been laid along the lymph node tracks to treat for any lymph node disease. But we've seen an evolution, particularly when it comes to surgery. So we've moved away from that original radical mastectomy to now the era of breast conserving surgery, where the patient undergoes a lumpectomy and breast conservation. And we've seen that delivering radiotherapy after breast conserving surgery actually helps to halve the rate at which the disease recurs. It also shortens the breast cancer death rate by about 1/6. And this is based on the publication in The Lancet of a meta-analysis of 17 randomized trials with over 10,000 women. And it showed, as you can see here, at 10 years, any first recurrence, there was a 15.7% improvement in reducing that risk of recurrence. And you can see there as well, almost a 4% improvement in breast cancer death when you looked out at 15 years by adding adjuvant radiotherapy to breast conserving surgery. And so that really has painted the landscape of where we are today. So if we look at the appliance of science and how that's influenced how we as radiation oncologists treat patients, well, again, if we cast our minds back, this is a slide taken from 1905 from the Royal London Radiotherapy Department, which at the time, this was state-of-the-art radiotherapy, where patients became directly involved in the delivery of radiation to themselves by applying these applicators on their body where the site needed to be treated. But through the advent of computer technology, which really has influenced all aspects of medical care, we've seen a huge transformation in how we deliver radiation. So we've seen the application of our understanding of anatomy in breast cancer radiotherapy. So here you can see how by simply asking the patient to take a comfortable deep breath and holding their breath, you can increase their lung capacity, moving the target away from the heart. And so this is what we call deep inspiration breath hold. And you can see here how such a simple maneuver can help to spare the heart from radiation and reduce the risk of long-term cardiac complications. It's through our integration of diagnostic imaging now that we really can define all the different parts of the patient who we're treating. So here you can see a CT with all the different thoracic structures outlined. And this can be applied to radiotherapy planning. And so these days, modern radiotherapy typically involves defining the targets and the organs at risk that we wish to avoid from irradiating. And this has led to the development of consensus atlases that we can apply to our patients. Here's an example of the ESTRO consensus guidelines on target volume delineation for elective breast radiotherapy treatments. And so by defining volumes and by harnessing modern radiotherapy techniques, we can now essentially sculpt the radiation dose that we deliver to our patients. This is an example of more traditional radiotherapy on the left, compared with what we describe as intensity modulated radiotherapy, where essentially the machine sculpts the dose to the target that's been defined. And what I hope you can appreciate is that it helps us to reduce the dose of radiation to the organs at risk within our patients. And that reduces toxicity and long-term unwanted side effects. And so, as I said, through the course of the last century, radiation has become more targeted, and we as clinicians can sculpt the radiation doses to the targets within our patients. But that wouldn't be possible without all the various multidisciplinary team members that make up the radiotherapy departments in which we work. So all of these members really are key to achieving what I've described. So over the course of the last 50 years, what we've begun to see is a reduction in local relapse after whole breast radiotherapy through all these various different measures that have gradually improved outcomes bit by bit. And you can see now that as we've moved into the 21st century, our local recurrence rates have reduced to often less than 1%, which is very impressive. So now let's talk a bit about radiotherapy itself and the evidence behind hypofractionation, which is what we do routinely. So hypofractionation is essentially delivering radiotherapy over a shorter period of time, either fewer days or fewer weeks than standard radiotherapy. Before we adopted it as our routine approach to breast cancer care, we were concerned that hypofractionated radiotherapy could lead to increased toxicity and worse outcomes, but the UK and Canada pioneered this approach over the course of several decades. As a consequence of that now, we have lots of clinical trials demonstrating the value of hypo and extreme hypofractionated radiotherapy, which I will take you through now. So if we look at the long-term results of hypofractionated radiotherapy for breast cancer, the paper by Timothy Whelan et al., published in the New England Journal of Medicine, demonstrated that comparing 5 weeks of radiotherapy with 3 was safe with local control rates as good as traditional radiation fractionation approaches. But that led then to what we now describe as ultra hypofractionated radiotherapy, where each day the patient receives over 5 gray per day. And that means we can shorten radiotherapy schedules from 3 weeks down to 1 week. And there's no better example than the Fast Forward trial. So the Fast Forward trial randomized patients with early breast cancer into 3 arms, 3 weeks versus 1 week, with 2 different dose levels for the 1 week randomization arms. The 10-year data was presented in Vienna in ESTRO back in May, and I'm pleased to say it showed non-inferiority for the 5-fraction regimen, which has now become a standard of care, demonstrated here by the pink line. It's shown non-inferiority in terms of recurrence-free survival, breast cancer-free survival, ipsilateral breast cancer recurrence, which was the primary endpoint of the trial, but also in terms of toxicity as well. So here you can see patient-reported outcomes at 10 years, which does not show any significant difference in toxicity by shortening that 3 weeks of radiotherapy to simply 1 week. One of the sub-studies that took place in this study was also looking at the safety of delivering 1 week of radiotherapy to the nodal areas, including the axilla, the supraclavicular fossa, and the internal mammary chain. And the 5-year data was also presented at Vienna ESTRO 2025. And I'm pleased to say that it also showed no inferiority between 5 fractions versus 15 fractions, both in terms of patient and clinician reported toxicity. Also in terms of arm and hand swelling, what we describe as lymphedema. And here you can see specifically lymphedema at that 5-year assessment point with no statistically significant difference. And as a consequence of this, the conclusion from the trial is essentially that 26 in 5 seems to be non-inferior to 40 in 15 for arm and hand swelling. And it seems to be safe with no evidence or no cases reported of radiation-induced brachial plexopathy. Obviously, we await now the longer-term trial results as and when they'll be published in future. And shortly in the UK, we're about to undertake the largest radiotherapy trial in breast cancer that's ever been run, and that's the Fast Forward Boost trial, where we look to integrate a boost into that 5-fraction regimen of radiotherapy, and that's going to involve almost 5,000 patients needing to be recruited. And so I look forward to the results of that study probably in a decade from now. But there's also look at further hypofractionated approaches. So here's studies looking at just a single fraction of radiation, both preoperatively and intraoperatively. So these trials are ongoing. See if you can deliver radiation safely in a single dose. And so the summary of these randomized trials is that it's convenient for patients, it seems to be more cost effective, it has similar local control rates and survival, and the cosmesis is good to excellent with hypofractionation. And as a consequence of this, you can see here the RCR has adopted this into their latest publication as a standard of care approach for breast cancer patients. So if we now think about partial breast radiotherapy, so rather than irradiate the whole breast, is it safe to deliver radiotherapy to the area where the tumor once was? Well, I'm pleased to say that yes. If you select your patients appropriately, using the appropriate mechanism of delivering that radiotherapy, we have strong trial evidence now demonstrated that partial radiotherapy is safe, both from the UK import low phase 3 trial, but also through the Florence trial, which accelerated the radiotherapy to just 1 week, which showed that there was no significant difference in terms of invasive breast cancer recurrence, nor any adverse outcome in terms of toxicity and cosmesis. And so now we have clear guidelines internationally helping us to select patients appropriately for partial breast or partial accelerated breast radiation. If we now look at the omission of radiotherapy after breast surgery, we do have studies that show it's safe, for select patients to avoid radiotherapy altogether. So the PRIME2 trial, looking at patients over 65 years of age with early breast cancer, showed that you could treat them with adjuvant endocrine therapy alone rather than radiation. We've also seen the results of the CALGB 9343 study, again showing that you can avoid radiation through the use of adjuvant endocrine treatment in older women with low-risk breast cancers based on their histopathological features. And there's also trials now ongoing looking at using biomarkers and molecular profiling to help us select patients who can avoid radiation and who instead may be able to avoid adjuvant treatment altogether or simply endocrine treatment alone. If we now look at the role of radiation in locally advanced breast cancer, here you can see that the meta-analysis of over 8,000 patients in 22 randomized trials demonstrating that radiotherapy after mastectomy and axillary surgery improves local regional control and also reduces the risk of breast cancer mortality. And that's why these days, again, it's considered standard of care to consider these patients for post-surgical radiation treatment. In terms of post-mastectomy radiotherapy, again, we have guidance on how we should select our patients appropriately. But importantly, we've also seen last year the Supremo trial report, which showed no overall survival benefit in patients who were selected for post-mastectomy radiotherapy following axillary clearance, with no significant difference in local control nor distant disease recurrence. And so finally, as we move into the realm of how do we manage the axilla, we've got the results of the Amoros trial showing that you can avoid axillary clearance now, substituting it with adjuvant radiotherapy to the axilla in appropriately selected early stage non-palpable lymph node patients. We've also got the results of the Otisor trial, again looking at the role of substituting surgery with radiotherapy to the axilla, again showing no significant difference between those two groups. And most recently, we've seen an interesting trial presented, essentially the B51 trial presented at San Antonio in December of 2023, looking at the role of no further radiation, particularly in terms of regional node radiation, in patients who've had a complete pathological response in their nodes to neoadjuvant chemotherapy. What this showed is that patients who were randomized to no regional node irradiation did not seem to have any increased risk of invasive breast cancer recurrence, nor a detriment to their overall survival. And as a consequence, they concluded that certainly at this 5-year assessment period, it seems as though it may be possible to select these patients to omit radiotherapy to regional nodes on the basis of superior outcomes to modern SACT treatments. And so finally then, to summarize, I think it's important that we remember for all our breast cancer patients, it's important to discuss them in an appropriate MDT setting. We should apply the best evidence to their care, use the most appropriate radiotherapy treatment technique that we have available to us, use the best radiation technology we have in our departments, and ensure that when we review that radiotherapy plan, that we're happy that it's the best that it can be. And let's not forget, it's important to monitor these patients for short and long-term side effects post-treatment. And that's the end. Thank you very much.
That's great talk, John. Lovely overview up to the point, which is great. Now, please, if you have any questions, please put them on the Q&A section. And the next speaker will be, and also we had a problem with the Russian channel. It's working all okay now. So if you want to listen to anything in the Russian channel, it's active, along with the Italian, Arabic, and of course the Spanish channel. Now, we're not making the life for radiation oncologists easy, and we're complicating things as surgeons. We're doing lots of oncoplastic procedures. We're cutting things from here and there and everywhere, and making their planning a bit more difficult. But also, when you have difficulty in planning, you have sometimes problems with how things look with oncoplastic breast surgery. And we have the lovely Fady Geara, and Fady is one of the oncologist at Cleveland Clinic in Abu Dhabi, and he's going to shed a sight on that. He's going to talk to us about radiotherapy and oncoplastic breast surgery. Fady, the next 15 minutes are all yours, and we'll take all the questions after we finish all the talks.
Thank you, Yazan, and thank you everyone for joining us. I'm sharing my screen now, and all good. You see my screen?
That looks perfect, Fady.
Okay, so as Yazan introduced the talk, I will be talking to you about radiation therapy with oncoplastic surgery. This is a narrow topic after hearing all the review about radiation therapy treatments for breast cancer. Here is a very narrow topic dealing with the topic of oncoplastic surgery and using radiation afterward. I have no disclosures, and this is the outline of the talk. I will be talking about briefly the oncoplastic breast surgery types or levels, indications of radiation therapy boost, which is affected by the oncoplastic procedure, and the tumor bed localization challenges and how we can go around them, and clinical recommendations and a couple of clinical cases at the end. So in oncoplastic breast surgery, there are levels of complexity. Level 1 is considered as a small volume of resection. Less than 20% of the breast is resected, and it usually uses volume displacement, not replacement. Typically, the procedure is glandular reapproximation. Very often, peri-aortic incisions are made and local advanced flaps are made. The breast size suitability is medium to large, and there rarely a need for symmetry for the other breast. Level 2 is the next level of complexity, where more volume of the breast is resected, about 20 to 50%. It uses volume displacement and also sometimes replacement. It is associated with reduction mammoplasty, mastopexy, or extended parenchymal reshaping. Often we need to do symmetry adjustment for the other breast. Again, these are terms of surgeons. I'm not a surgeon, but this is just to introduce the topic. Some reports indicate level 3, where you get more than 50%, or even level 4, where you are near total mastectomy. I will not go into this. The topic of today is to deal with level 1 and level 2 and how to apply radiation therapy after breast conserving treatment. Why we need oncoplastic surgery is because when you apply only a simple lumpectomy and primary closure, that's when sometimes or very often you end up with this poor denting of the breast and poor cosmetic outcome. This is not acceptable. As technological advancement in surgery have been done, we know how to, surgeons, our colleague surgeons know how to do better, and they offer our patients a better option. And this is the better option. This is a patient with a left breast CA, not seen on this image, but this is the end result of a oncoplastic breast surgery, where you have a peri incision and another incision below the nipple, and the shape and the volume of the breast are completely adjusted and symmetrical. So in brief, what is the clinical outcome? What this procedure of oncoplastic surgery has done, has brought to breast surgery? We can do, surgeon can do better resection or bigger resection specimen, which means that you have more indication for breast conserving treatment. You have wider margins because you are free to move around, and this means that you have a safer surgery and more complete surgical resection, lower rates of positive margins, lower rates of reoperation because you don't have a transection or positive margin, lower rates of completion mastectomies, again for the same results, and better cosmesis because of the nature of the procedure itself, because you are moving flap and filling gaps and cavities. And in terms of oncologic control, you have similar rates of local recurrence. So why it is challenging, why radiation therapy is being challenged by this procedure is because the loss of tissue architecture and tumor bed anatomical localization has made it very difficult for boost planning. And this is very important because in radiation therapy, we still use a boost. I mean, the indications of boost have changed or are probably drifting or decreasing, but we still need a boost, and I will show you why. There are indications, imperative indications for boost for women less than 50, for women with the positive or closed margins. Some people use 1 millimeter like myself. Some people up to 2 millimeters, they consider this as a closed margin and they use a boost. DCIS with high risk features, they always give a boost because they do better with a boost. Relative indications, LVSI or lymphovascular space invasion, high-grade tumor, triple negative or HER2 positive, which are very aggressive tumors, and patient with tumor with extensive intraductal component, although this has been debatable, and that's why I put it as a relative. So why we feel that there is a boost? There is a big study that everybody in the field of radiation therapy know about. This is the URTC trial that showed improved local control with the boost delivery, but no survival difference. This is for all patients. This is a 20-25 years follow-up, published the last follow-up, last update in 2015, showing for all patients benefit with the boost is more pronounced for young women, less than 40 and less than 50. The benefit continues to be seen above 50, but it's much, much smaller. So for women less than 50, the overall trend of the community and radiation oncology is to deliver a boost for patients after surgery. So when they get a surgery with oncoplastic surgery, then we have a problem, and let's review these challenges. The tumor bed localization challenges, the tissue rearrangement, volume displacement techniques that are used in oncoplastic surgery. The residual breast tissue is mobilized and rearranged to fill a defect, and therefore the original tumor cavity is displaced, making it non-anatomic and hard to locate in the post-op setting. And also you have sometimes seroma or no seroma, and the seroma may be also not at the original site of the tumor bed. So the seroma could be misleading, and sometimes because you have good approximation, you don't have the seroma. So this is something to also that creates challenges in the post-operative planning. When you use a volume replacement flaps, this becomes even more challenging because tissue brought from outside the breast, inside the breast to create volume and reshaping of the breast is replacing the excised tissue and in a non-symmetrical and unclear way. So the tumor bed becomes obscured and very difficult to draft or draw a boost volume for an original tumor cavity after such treatment, such surgery. Also, the scar and the skin are misaligned with the tumor volume and tumor bed. In the past, in the old tumorectomy, simple tumorectomy, the incision used to be on top of the tumor. Now, with this procedure, the scar or the incisions are not aligned; they are completely different place. Often, our periareolar where the tumor is completely in not below the nipple areola. So it's very difficult to use this as guidance. So very important to remember that these procedures do not have the same old alignment of scar and tumor. Imaging limitation, and because of all the above, whatever we have in imaging, this imaging is not this easy to bring into the registration and tumor planning. Yet we still need to do it because visual evaluation and sometimes registration, although it's very difficult, especially because when you do a breast MRI, we do it prone. Even with the most sophisticated deformable fusion, you will not be able to bring the shape of the breast in the prone position to a shape of the breast treated in the supine position after surgery. Unless you do a prone RT, then this breast MRI is very difficult to use in co-registration and image fusion. Post-operative scans are also not easy to interpret because of the distortion. So imaging is very important to review, but the utility in planning, in fusion, in co-registration is very limited. So for this, what we need to do, how we can go around it, how we can go around these challenges, I think marking tools are very important. Metallic clips, usually you have to go at least 4 or more. There is a special way of doing it and needs to be done in a very systematic way to outline the tumor cavity. And there is some issues with metal clips because they are 2D markers, and they can be displaced, especially after healing and after changes in the anatomy of the wound. That could happen. Sometimes if patients receive post-operative chemotherapy and there is a long term of healing, then before they come to radiation, these clips could be displaced. A little bit better, the 3D radio-opaque markers, I put here a couple of types, the Veraform, that's the one we use here, or Biosorb, are more useful usually for RT plannings, are more stable, and they give a more volumetric outline of the tumor site. Here's some examples with the clips. On the right side, you have the clips, and they are all over the place. Sorry. And you have the contours, and you see the different contours is because this is a study that looked at variation in contouring among physicians, and you can see the difference. And here, without clips, people using seroma and using imaging. So very large variation in using these clips. The clips challenges, as I was saying earlier, they are inconsistent sometimes in placing them, especially if there are no standardized protocol among the surgical group. The best is to use 5 to 6 clips around the surgical cavity, and be aware of clip migration, and use immediate postoperative imaging if the patient is going to for long adjuvant chemotherapy after surgery. And it's very important to differentiate those from surgical and vascular clips. And sometimes you need to have the help of surgeons with you on the contouring to differentiate them between especially the vascular markers and clips and the tumor bed clips. This is an image of the Veraform, which is a linear opaque, radio-opaque suture that the surgeon can use in a cylindrical way or in a helical, in a very 3D spherical way, covering the surgical site. Here you can see, you probably don't see the line, but it's visible here, and it's used to delineate the tumor bed. This is an image taken from the website online, Biosorb. This is how it looks, and this is how it looks on the patient. So what are the recommendations when we deal with oncoplastic surgery for breast conserving surgery? The multidisciplinary approach is of paramount importance. Discussion between the surgeon and radiation oncologist, anything that is not clear needs to be discussed and clarify with the surgeon. Optimal use of preoperative imaging, again, we discussed that. It's important to review everything, to have an idea where anatomically the tumor was. Detailed operative reports are essential. This is for our colleagues in surgery to say what they've done, and it's very important. Use of surgical clips, as I indicated, or better, use 3D markers, which are more stable, and they give a better contour of the tumor bed. And finally, you have to weigh the need for boost when extensive oncoplastic surgery is done. What I mean by that is the benefit of the boost has to be weighed versus the cavity. Sometimes we don't know exactly where to go and where to boost, and we are forced to create a large volume. And this benefit of large volume boosting in the absence of very severe criteria for boosting may not be needed. And I think here we need to use some clinical judgment. So some clinical cases, 2 cases from real world. This is a 41 years old woman with T2M0 M0 triple positive breast cancer. She had neoadjuvant chemo and anti-HER2 therapy. She had a partial response, which is not unusual with triple positive, and she was followed by oncoplastic surgery. And here, our colleague from surgery, they use the Veraform. This is they use always, particularly this particular surgery, use always a Veraform at the bottom of the surgical bed, and it goes upward in helical form to show the tumor bed. And this is a very good demonstration here. And here the isodose distribution with the simultaneous integrated boost to the surgical bed. This is another case, a 45-year-old woman, T2N1, sorry, M0. She had a large positive lymph nodes. Actually, she had an intermammary node. And ERPR negative, HER2 positive, neoadjuvant chemo and anti-HER2. She had a CR, typical of HER2, and she had also a oncoplastic procedure. This is the MRI after the neoadjuvant therapy. There is nothing. And when the surgeon did the surgery, of course, they put some markers in the tumor bed so they can guide their resection. And this is a Veraform application where you can see the line, the section of the radio-opaque material. And this is a sagittal projection of the tumor bed. So in conclusion, oncoplastic surgery offers better conservative options and cosmetic outcome for breast cancer patients. It involves breast tissue volume displacement and/or replacement, which causes anatomical distortion of the tumor bed and causes trouble for us. This has created significant challenges for applying local boost after whole breast radiation. Same for the use of partial breast irradiation, which I did not discuss here, but this is the same challenge. Close multidisciplinary work, usage of imaging data, and insertion of tissue markers during surgery help reducing these challenges. And finally, refining boost indications, particularly in low-risk elderly patients, may also help address these challenges. And I thank you for your attention.
That's a great talk, Fady, and lots of questions I'm sure will be in the Q&A section later. So if you have any questions about any of the talks, please put them on the question and answer section. We'll try to go through as many of them after we finish all 4 talks. Now, everything will have complications, and radiotherapy will also have complications, and Suzy Cleator is going to give us a talk about that. So Suzy, the next 15-20 minutes are all yours. Perfect.
Hi there. Hi. Thank you very much for inviting me, Yazan. I'm a clinical oncologist, so I do both radiation and systemic treatment for breast cancer in the UK. So I hope I'm going to reassure you to some extent with the talk that I'm going to give you. I haven't got any relevant disclosures. So before we launch into talking about toxicity or complications, I want us just to think about the structures that we've got within the breast. So we've got the inherent soft tissues of the breast, we've got the skin, we've got components of reconstructions. This is going to relate mainly to aesthetics, but comfort only. Comfort also. We've also got more sensitive structures. We've got the lung, the heart, the brachial plexus, bones, including clavicle and ribs, and of course we've got the lymphatics. I've included at the bottom there in brackets thyroid and carotids because I am often asked this by patients, but I reassure them that we don't see hypothyroidism and we don't think the doses that we use increase the risk of strokes. So just by way of background, and John touched on this to some extent, there is a whole science and a discipline of modelling around toxicity relating to radiotherapy, and we have a concept of a tolerated dose for each organ in the body. And the tolerated dose is going to depend on the biological dose that we deliver and also the volume that we treat, or the proportion of the organ that we treat. And the biological dose, as John mentioned, depends on the total dose, but also the fraction size or package size that we deliver it in, how quickly we give it. Do we give it daily or do we give it once a week? The inherent sensitivities of the tissues, and we've got constants for each tissue. And it may be of some interest to learn that the alpha-beta ratio that we believe is correct for normal breast tissue is more or less the same for breast cancers. And this is when you've got a close match on the normal tissue and the cancer on the alpha-beta ratio, it means that there isn't a particular advantage to fractionating or splitting up your dose into lots of small packages, as we do when we're treating a lot of brain tissue, for example. We've also got structures of particular sensitivity, such as the left anterior descending artery. But what I would like to say is that when we treat the breast, we are not using high doses. We're only using a microscopic dose. It's much lower than is used for head and neck cancers. We're actually using biologically lower doses than we've used in the past. And we can actually largely avoid sensitive structures. We don't have a problem with the carotid, with the cord, for example. And at the bottom, I've just included that there are several kind of appendices of tolerated doses per organ that you can go to. And I've put the heart below here, and it tells you, what level of complication is associated with giving what dose to what proportion of the heart. What I would say is with breast, we're incredibly cautious. We are way below these doses because a lot of our patients do very well, and we really do not want to do harm. So there are some things that I'm not going to talk about because they are historical toxicities. We just don't see brachial plexopathy. There was a very unfortunate incident in the UK in the 1970s where a group of patients were treated with a bad technique. There was overdose of radiation fields over the brachial plexus, and the patients formed an advocate group called RAGE, and they were compensated, and I hope that won't happen again. I have seen a small number of cases of bone necrosis, so particularly lateral end of the clavicle, but in patients who were treated many years ago, when we used to have much more in the way of hotspots, we have much more even doses with modern technology. I have seen woody fibrosis of the neck with muscle atrophy, but again, historical radiotherapy. Pneumonitis, patients worry a great deal about their lungs. We do get it on scans. It does look quite dramatic, particularly in the first few weeks after radiotherapy, but we never see it clinically. We don't see marked acute toxicity very often at all, apart from large-breasted women, ptotic breasts, or if you're using bolus, and telangiectasia and depigmentation, which of course are a particular problem in pigmented patients. I mean, we see a lot less of that because that really is something that follows on from moist desquamation, which we see much less of. So our ongoing challenges, I would say, are cardiac dose. And I'm going to talk briefly about breath hold. John's already been through that. I'm going to mention arcing techniques. John's already mentioned that, but I'm going to talk about protons as well. Lung dose, I'm going to mention that briefly. Staying within safe doses to the lungs is not normally a problem unless we've got unusual anatomy or if there's underlying lung disease. Sometimes ptotic breasts can cause this problem. Pacemakers are a challenge, and you essentially can't treat the left chest wall or breast with a pacemaker in place, and it's not easy to move pacemakers. I normally tell patients that the conserved breast deals with radiotherapy very well, and that quite often you can't really tell someone's had breast radiotherapy. I think we are seeing a bit more lymphedema than we used to see, although it does tend to settle by 2 years. We do see involutions sometimes, and morphia is a very rare but very severe idiosyncratic reaction to radiotherapy, whereby the breast becomes very fibrosed, like a rock, really. And most cases, though not all, are probably associated with underlying connective tissue disease. We have a particular challenge with radiotherapy to the augmented conserved breast, and also, of course, the implant reconstructed breast. To a lesser extent with the autologous reconstructed breast, I'm going to mention a bit about radiotherapy and lymphedema of the arm, but I think we have very poor data, and I'm going to very briefly touch on second malignancies. So again, before I go into these specific subjects, we've got better delineation than ever. We've got better verification of position. We've got fewer hot spots. We are using lower doses. We've got breath hold, arcing techniques. We're using partial breast radiotherapy. We don't use boosts as much. We don't use bolus nearly so much. And we are entering into a stage where we're going to probably be de-escalating our radiotherapy further. I'm not going to talk about NSABP B51, but John mentioned it. So this is what I'm going to focus on. So starting with arcing radiotherapy, I've only got one slide on this, and this is just to emphasize when it can be useful. This is when we want to conform our beam edge to the curvature of the chest wall, when we want to essentially produce a convex or concave beam margin. We are very well served by tangents in most patients, whereby we have a beam coming in here and an opposing beam here. If we were to use opposing beams on this patient and treat the whole of the breast tissue and cover the medial tumor bed, we would be adopting that beam angle, and we would be treating more than half of this lung to an ablative dose. This is a case actually I treated last week. So she's got very ptotic breasts. We don't like treating people in a shell. They get horrible toxicity. It was a very medial tumor bed here, but what we were able to do was bring the beams in an arcing manner as it was moving across the patient, with bits of lead coming in and out to modulate the energy of the beam, and to produce a dose. It's like a contour map that conforms very well to what we want to treat. So I'd say tangents are the default. We don't really like using VMAT unless we have to, because you've got a low dose bath, but it is useful for cases like this, and when we're treating the internal mammary chain here. Cardiac dose. John's talked about technique. I'm not going to talk about technique, but the issue is, of course, here that the heart can be right up against the chest wall, and in particular the LAD. And we've got very nice data from this publication by Sarah Darby, showing that there is a linear relationship between the mean heart dose to the heart and the percent increase in the risk of major coronary events. So for every 1 Gray increase in mean dose, we're getting a relative increase in risk of 7%. So if you've got 3 Gray mean heart dose, which is much higher than most of our patients get, that's increasing the relative risk by 1/5. And this is borne out by trial data relating to nodal radiotherapy versus no nodal radiotherapy. When you compare the older trials versus the newer trials, when you look at the older trials, breast cancer mortality, you can, sorry, I don't want to look at that one. Let's look at the one below. This is non-breast cancer mortality. You can see in the older trials that in fact you've got worse mortality when you treat the nodes, but in the newer trials you've got a survival advantage, and that almost certainly is because of heart dose. And this is just a nice case showing how well the heart can get out of the way with breath hold. Our patients are terribly worried about heart dose. I think we should reassure them. This is a table that shows your age of irradiation and your absolute risk of a radiation-related ischemic heart death overall, according to the mean heart dose that you're getting, with no cardiac risk factors and 1 cardiac risk factors. And this is if you've already got a cardiac risk factor. And this is, you know, if you've got a really high heart dose, and these are really small absolute increases. Most of our patients are going to be down here with modern technology. So I'm going to mention protons briefly. So we in the UK have got 2 proton units, and I think the need in breast is very niche, I would say. This is a case I treated a year or so back. This is a patient with terrible sarcoid ILD and lymphadenopathy. Most of this lymphadenopathy is sarcoid. We think at least one of the nodes under the arm was related to this horrible necrotic triple-negative breast cancer. In her augmented breast, it turned out she had a BRCA2 mutation. No evidence of metastatic disease. She had ambulatory oxygen, but was actually performance status 1 on this. And we were told she wouldn't survive a general anaesthetic. We embarked on what we thought was probably palliative carbotaxol, but she coped with it really well. And in the end, our surgeons did do a mastectomy and level 2 clearance under local. She had residual disease. Such a shame not to be able to do radiotherapy, but we didn't think we could do radiotherapy with her lungs. But we managed to get funding for protons. She had it with no acute or long-term toxicity, and she's now completed adjuvant olaparib as well a year out from that. And this is just another way of looking at the dose. This is delivered by protons. We don't do it in breath hold yet. And again, we managed to bend around the heart. Protons delivers radiotherapy in a different way. It's not a penetrating beam that goes in one way and out the other. It actually deposits the dose at a specific depth. So you can deposit the dose up to, but not beyond, the heart and the edge of the lung. We have funding in the UK now for patients with Meattini, patients age 30 or under, or you can go to a panel for exceptional cases, as we did for this. And we have a trial called the Pardo study, which is a randomized study in the UK, which is going to try and define what kind of benefit we're seeing from this very expensive resource. I haven't got much to say about breast lymphedema because after axillary radiotherapy, because I think the data is very poor. So I think it's in general accepted that the risk of arm lymphedema after axillary radiotherapy and a sentinel node biopsy compared to an axillary node clearance ANC is lower. We don't really know to what extent axillary radiotherapy after axillary node clearance increases risk. I'm sure that the big determinant is the surgery and the extent of surgery. We don't even know how to match the surgical and radiotherapy fields. It's an issue. Many of the large international randomized trials have actually treated levels 1, 2, 3, 4 of the axilla even after a level 2 clearance. In the UK, we try to match to surgical clips, but we know the surgeons aren't necessarily putting clips in at the superior extent of dissection. So we know in Amorous, which was for patients with positive sentinel node radiotherapy to the axilla versus surgery, that in the first publication, the lymphedema rate in the surgical arm was apparently 28% versus 15% with radiotherapy. But this is from a later publication, which is showing much lower rates and not such a big difference. This is the Seminac study, which is showing that lymphedema type toxicities were much greater in patients who'd had an axillary node clearance versus those that had had a sentinel node biopsy. But remember, most patients in both arms got radiotherapy. So we're comparing sentinel node and radiotherapy versus radiotherapy, axillary node clearance and radiotherapy. So this is just my impression. I am not seeing severe arm lymphedema after sentinel node biopsy and axillary radiotherapy yet. You know, I'm seeing grade 1 maybe. And of course, these trials that are published so far, they're not giving us the grading of the lymphedema. I'm just not seeing the kind of severe lymphedema that we see with surgery with radiotherapy. Second malignancy, I'm not going to go into this in huge detail. This is a really useful publication from the Early Breast Cancer Trialist Collaborative Group. And I think patients worry about second malignancy. I mean, I when I'm consenting them, I can see it's causing concern, but I tell them it's like the sun and skin cancer. It is radiation, but it's a particular problem for smokers. This paper suggested in long-term smokers that the risk was about 4% of a radiation-induced cancer, and that's a lung cancer essentially. Much smaller for non-smokers. This is a table from the paper, and these are the kind of these are the cancers that we're seeing. But I think we do have to weigh up in patients who may be at low risk of recurrence even without radiotherapy. We have to weigh up the risks and benefits in smokers, particularly in the kind of prime 2 type population. So finally, I'm going to move on to cosmesis. Now, we have a particular issue with conserved augmented breasts. I'm seeing that partial breast radiotherapy seems to be causing less of a problem. These patients, I think they benefit from seeing a plastic surgeon at the outset. They sometimes come to me, and it hasn't even been mentioned in the referral that they've got augments, and it hasn't been discussed with them that the radiotherapy is going to impact. Aside from augmentations, we do have particular problems from seromas causing induration, and I think radiotherapy makes that worse, and we've not got much data. We do have a problem with large breasts. That's probably hotspots. There's a lot of chatter out there about patients who've had complex mammoplasties having more breast edema. It needs to be looked at. We don't really know about licaps and other mini flaps, how well they do with radiotherapy. My impression so far is encouraging. So overall, we don't have much data on risk of lymphedema and so on, but certainly from the fast forward study thing, it's encouraging. You've seen these from John. I'm looking here at breast swelling. This is the patient reported outcomes of breast swelling, but in this study we don't think many people, it was done a while ago, we don't think many people had complex mammoplasties. Look at all this red here, and this is the clinician assessment at 10 years. I just think, look at the difference. Very much these are the patients. Of course, this is a combination of surgery and radiotherapy. This is the clinicians. So finally, reconstruction. So I think we all know that the impact of radiotherapy on an implant reconstruction is significant. It's less for an autologous reconstruction, but the autologous reconstruction is a very long operation, and it's a very big investment for surgeon and patient. So very quickly, I think this is a very useful data set from the US, MROC. It was a prospective multi-center cohort study looking at irradiated, non-irradiated patients who'd had implant and autologous reconstruction. And it was very reassuring from the point of view of autologous reconstruction, with no differences in rates of complication between radiated and non-irradiated. But there were big differences in terms of the breast Q questionnaire, with the irradiated implant always coming out at the bottom, the unirradiated autologous always coming out at the top, but not much difference between the irradiated autologous and unirradiated. And this is reconstruction failure rates clearly much higher with implant and radiotherapy. So this has led to an interest in the possibility of preoperative radiotherapy just prior to an autologous reconstruction to essentially treat what's going to be left behind after mastectomy, the skin envelope, but to not irradiate what's going to go into the skin envelope. So in the UK, we've got a trial following on from this Pardo pilot study called Pardo 2. It's been funded by NIHR. There's actually a sister study occurring in Belgium as well, and the primary endpoint is going to be breast satisfaction at 2 years, and it's randomized between preoperative versus postoperative radiotherapy. I would encourage people to think about this trial. We still have units in the UK that will not offer immediate reconstruction to some people having autologous recon. So in conclusion, I would say patients are more worried than, I said this at the beginning, but patients are more worried than ever about toxicity. Patients go between me and John for second opinions because they're petrified, and we're often just trying to reassure them that risk of toxicity is small. For some patients, though, I'm thinking particularly in terms of second malignancy, the benefits will be outweighed by the risks, but this is not many. And I've just put a link at the bottom there to take people to the UK National Consent Forms. You can find them by Googling RCR, National Consent Breast Radiotherapy. And I think they're a very useful and comprehensive consent form that can be used. Okay, great.
That's perfect. Thank you for that. It's a great talk, Suzy. And there's quite lots of questions in the Q&A section. So if I can trouble John and Fady, if he's still online, and Suzy, if you can have a look at those, and if you want to answer some of those, and if there's anything to be answered live, we'll do that in the next 20 minutes, because the last talk is by Icro Meattini, and Icro is not able to join us today, but he sent a recorded talk, and it's about the use of radiotherapy in relation to primary systemic treatment. Sorry, I'm making a mess out of my computer as usual. Let me see. Can you see my screen? Perfect. Because I'm a bit lost with this. You think after 75 webinars I can get it right, but I'm not getting it right still. So bear with me for a minute. Can you see only the talk, or can you see the whole screen? It's all fine. Is it looking okay, Ricardo?
Icro Meattini, Associate Professor of Radiation in Oncology at the University of Florence, Italy. It's my pleasure to be with you today during this webinar. So this is the chance to discuss about how to integrate radiotherapy into the current treatment concept of primary systemic therapy, and had this chance to discuss this topic during the last ASCO in Chicago. First of all, why we have to rethink radiotherapy in the era of primary systemic therapy, why this topic, and right now, since the escalation in breast cancer is a topic for surgery, systemic therapy, radiation therapy, and radiotherapy should be considered not in isolation, but as a part integration of the other tools that we had in the multidisciplinary setting of breast cancer treatment. So first of all, some insights from radiotherapy after upfront surgery in order to understand better the primary systemic therapy field. With no doubt, basically surgery represented the perfect example of how to optimize the process of a de-escalation strategy. We reach also the eliminating breast surgery in specific, provoking, of course, data in specific setting in highly selected patients, differently in the field of radiation therapy. What we have learned from the previous studies in terms of the escalation of treatment, especially in the axilla. Basically, trials, phase 3 trials, as the ZU11 and the IBC SG2301 help us to identify lower risk patients. At the same time, phase 3 trials as the DOTC 22922 with higher risk and the May 20 identify higher risk patients. So basically, where's the potential room for radiotherapy de-escalation in this specific context? In the low-risk patients, the ZU11, 2301-like patients, we, of course, may avoid axillary lymph node dissection and probably also nodal radiotherapy. So the room for de-escalation is axillary radiotherapy omission alone. But in the higher risk residual nodal plus patients, axillary lymph node dissection or regional node irradiation might be an option. So in this field specifically, axillary radiotherapy is going to replace axillary lymph node dissection, and the de-escalation strategy here is more an optimization of radiotherapy volumes rather than a pure omission of the treatment. It's important to have some insights from this specific setting. The PCDCG regional node irradiation meta-analysis on more than 14,000 patients, based on 16 trials, comparing regional node irradiation, not basically in the newer trials demonstrated that regional node irradiation led to a reduced recurrence rate, reduced breast cancer mortality, no significant effect on non-breast cancer mortality also. So this showing the improvement of the radiotherapy in this setting and reduce all-cause mortality. Even in patients with negative nodal status after surgery, after upfront surgery, so that not receive primary systemic therapy, and probably receive a benefit also in terms of survival, even in nodal negative status. Adding to this complexity scenario, the Supremo trial showed that post-mastectomy radiotherapy might be safely omitted in some specific patients, even PN1 patients, of course, with favorable profile, PT1 and 1, PT2 and 1, PT3 and 0 also, IFG3 and or with lymphovascular invasion that randomized to receive or not primary post-mastectomy radiotherapy, basically show no specific differences in overall survival rates and just for recurrence, with slight significant differences, but not impacting on overall survival. So the topic is quite hot, I would say. And unfortunately, concerning biomarker-based radiotherapy, there are several challenges. Some issues on study ongoing, the need for properly designed trials in terms of randomization, control group. Several studies include only treated patients, limiting, of course, predictive assessment of this biomarker in radiotherapy. The vast majority of biomarkers provide prognostic rather than predictive value. That is what we are looking basically for. So we really need for long-term validation. Many biomarkers lack robust clinical utility validation. So this is really a gap. And the main gap is the lack of reporting in terms of long-term clinical outcomes. So we still have no definitive data on the utility of biomarkers in radiotherapy. At the present stage, might complement, not replace standard of care tools. So entering the primary systemic therapy field, we really did a great job in terms of optimization of radiotherapy strategies in the early setting, where now we have level 1 evidence in terms of hypofractionation, lowering the dose, omitting the boost, reducing the treated volume thanks to partial breast irradiation, even omitting radiotherapy or endocrine therapy, depending on the Europa phase 3 trials in selected low-risk older adult patients. But honestly, evidence guiding radiotherapy decisions after primary systemic therapy still remains limited and less definitive at this stage. Since, of course, tailored postoperative treatments, it means a multifactorial decision process and an individualized approach related to several factors. Data from the MDC ACC basically show the regional node irradiation show no effect at 10 years in terms of local regional relapse in the World Series, but at the same times, there are some specific jeopardized effect of regional node irradiation. If you look at this study on several patients treated with mastectomy or conservative surgery in patients with clinical node positive breast cancer, basically you can observe how in the post-mastectomy radiotherapy setting, irrespective of the pathological lymph node response, there's an overall survival benefit in patients receiving post-mastectomy radiotherapy. But in the same series of reporting patients, no overall survival benefit was observed with the addition of regional node irradiation to breast radiotherapy in patients that receive a breast conservation. So we have no definitive data. It's a multifactorial evaluation at all. This is not a publication, but basically the concept is if you look at the multivariate analysis and the independent factor in terms of local regional recurrence, you can see that this is the number of factors that are related to the local regional relapse risk rather than the single independent factor. So it's the number of high risk factors that basically make the real risk for local regional relapse, and probably identify high-risk patients where an escalation of treatment is needed. Basically, in the absence, what typically happen in the absence of level 1 evidence, in significant variability persists in clinical practice, both regarding regional node irradiation in terms of survey and published registry data. So heterogeneity of treatment in this specific setting. Still concerning background, if we look at the impact of pathological complete response, that has been defined as a surrogate endpoint of overall survival, improved overall survival, event-free survival, especially in high-risk patients with biology, such as triple-negative, HER2-positive, HR-negative tumors that receive, of course, an anti-HER2 therapy, is really the target. If we want to look at the survival outcomes without radiotherapy, we have to observe the results of the MSAB PB18 B27 trials. But basically, pathological complete response after primary systemic therapy was associated with significantly improved overall survival, both in clinical node positive and clinical node negative patients without radiotherapy. Was allowed only after breast conservative surgery, limited to breast, no regional node irradiation. Basically, if we want to compare the 5-year local regional relapse stratified by clinical nodal status and response to primary systemic therapy, we observed that pathological complete response was the most important factor and stronger than the clinical nodal status in terms of local regional relapse at 5 years. And if we look at the 5-year local regional relapse stratified by tumor biology, we have to look at the NSAB PB40 trials. It's a trial on HER2 negative patients. Even in this case, if we look at the course of patients treated, and here radiotherapy was given at physician discretion without quality assurance, again, pathological complete response was stronger than tumor biology. So basically, at the very end, if we give radiotherapy without a quality assurance and at the physician discretion, what you obtain finally is that regional node irradiation was not related with a significant improved overall survival, distal-free survival, distal metastasis, or local regional relapse. But it's important not to misinterpret this data because there's not a quality assurance and not a specific guidance in prescription on radiotherapy. A very nice de-escalation study after primary systemic therapy is the RAP-CAMP study run in the Netherlands, where to evaluate the escalation local regional in CT1, 2, and 1 patients receiving primary systemic therapy according to a predefined consensus-based study guidelines. So patients receive radiotherapy depending on the risk and the response to primary systemic therapy. Assuming 5 years local regional relapse, less than 4% acceptable. And what we observe in this patient that received this predefined strategy of de-escalation of treatment, the 5-year local regional relapse was basically below 2.5% in the world series. So basically, allowing the hypothesis that it's safe to de-escalate treatment. And now we have the B51 trials presented in San Antonio 2 years ago and now published in the New England Journal of Medicine, first name Mamunas, that basically showed that patients with clinical node positive that obtain a pathological complete response randomized to receive or not after primary systemic therapy regional node irradiation have no differences in terms of invasive breast cancer recurrence-free interval, in terms of disease-free survival, and also in terms of overall survival rates. And now there's the full paper published in New England. Completely different, the scenario of residual disease after primary systemic therapy. Patient not eligible for the B51 might be eligible for the Alliance 011-202 trial. Patient with residual disease after primary systemic therapy randomized to receive regional node irradiation or not. Currently, the status of the study, the accrual is completed. Some preliminary data in terms of additional node positive in the axillary node dissection arm showed that 46% of patients had additional positive nodes in this arm. Basically, until final results available, clinicians should base decision on standard of care individual risk profile. And the vast majority of these patients receive also adjuvant systemic therapy. We don't know how to combine with radiotherapy. It's the case of high-risk CDK4/6 inhibitors, where no studies evaluated concurrent use of radiotherapy as CDK4/6 inhibitors. It's the case of two agents, of course. We know that it's safe to give concurrent radiotherapy and adjuvant trastuzumab with no increased rate of heart toxicity. And also in case of dual blockade with pertuzumab and trastuzumab, the main pivotal trials show no increased risk of cardiac toxicity. Patients that not obtaining a pathological complete response receive TDM1 in the adjuvant setting. 82% of patients enrolled in the Catherine trial receive also radiotherapy, given simultaneously with TDM1, with no statistical increase in terms of acute skin toxicity and radiotherapy-related pneumonitis risk. And BRCA1 and 2 patients receiving olaparib, that in these specific patients, after neoadjuvant chemotherapy, significantly improved survival in these high-risk patients. But the Olympia trial, the pivotal trial, had no data of concomitant radiotherapy, since patients should have completed the radiotherapy course between 2 and 12 weeks before trial enrollment. Concerning immunotherapy, the Keynote 522 trial showed that the addition of pembrolizumab significantly increased the event-free survival of these patients in the neoadjuvant and adjuvant setting. Initially, we cannot prescribe radiotherapy concomitantly. After a subsequent amendment, concurrent administration was allowed, and a good tolerance of the combination was reported. The creatiques of patients receiving triple-negative breast cancer, capecitabine, basically have no specific data concerning radiotherapy. 70% of patients receive radiotherapy, but per protocol, not intending to give it simultaneously. So we have a lot of uncertain data in terms of combination of systemic therapy and radiotherapy, safe for trastuzumab, pertuzumab, TDM1, pembrolizumab in the adjuvant setting, some warning for CDK4/6 inhibitors, capecitabine, and olaparib. And basically, so what we need, and we published this in the essential requirements for radiotherapy in breast cancer trials, regardless the primary endpoint of the trials that are investigating or not radiotherapy. This is the ESTRO consensus. The optimal requirements ask for use of predefined radiotherapy planning banks and quality assurance in terms of volume, dosimetry, quality control, and employee centralized quality assurance in trials is really essential to have good data and have good data in terms of safety. So the key takeaways, basically, there's a role for radiotherapy after primary systemic therapy in terms of de-escalation. This concept is under re-evaluation. Studies like RAPCAN or the trial B51 explore selective radiotherapy omission after good primary systemic therapy response. So emerging data support risk-adapted radiotherapy to reduce the treatment burden without compromising control. But be careful. It's important to design future de-escalation trial with an integrated approach, multidisciplinary, avoiding evaluating surgery, systemic therapy, radiotherapy as silos. High-level quality assurance and reliable reporting is essential. We have to consider interplay of cumulative impact of treatment modalities in order that an overlap of reduction across modalities may not lead to an intentional undertreatment. So what we are aiming for is a multidisciplinary design that ensures strategies that are safe, evidence-based, and reliable, applicable to real-world practice. So thank you very much for the invitation and for your attention.
It's another great talk. It's unfortunate that Icro could not be with us on this occasion. He has been on previous webinars. Now, for people that are online, it's great to see that we reached more than 500 at one stage. Now we still have about 460. So we'll start with the discussion. You will get your CPD points and certificates in the next week. So please be patient with me and I'll send them. But now let's start with the discussion. So we have Emma Spurrell, who's one of the oncologists that works in Harley Street, also and works in UCL and the Whittington. And we have also Michalis Kontos. He's one of the surgeons from Athens. Let's start with Emma. Emma, any comments about the talks?
Yeah, they were great, actually. From a perspective of medical oncologists, it's really nice to hear some radiotherapy talks, because this is the bit that I don't specialize in. So we've had some really good themes. I mean, obviously, some great pictorial themes from John, looking at how effectively now we emit toxicity to surrounding healthy structures, particularly the heart. I think it's very reassuring from Suzy to hear about the low toxicities, because actually I have to say I have a lot of patients who, well, not a lot, but I'm always surprised at the few that come through 6 months of chemotherapy and then don't seem to want to have any radiotherapy because they're worried about toxicity. And from my perspective, that feels like the wrong way around. I think we do have a lot of discussions at our MDT about cosmesis and clips and radiotherapy beds, and understanding perhaps some of the new techniques to help delineate that better. And then finally, of course, the sort of rapid advances in prime systemic therapy and how this interacts with our radiotherapy colleagues. And I had a few questions there. But I guess the first theme I was interested to talk a bit about is the axilla, and I don't know if we dare go into that really, but I had some questions about the axilla. Shall I go ahead, Yazan?
Yeah, please go ahead.
Yeah, okay. So I think I sit in a number of MDTs, but we struggle with the axilla still, I think, in terms of anything that de-escalates the axilla in a neoadjuvant setting, and who's eligible and who's not. And sometimes I think we feel reassured by the fact that, well, at least we've got radiotherapy afterwards. So if we how do we optimally pick our de-escalation patients? Is it based on nodal volume, or is it just purely on the biology of the response to treatment? And that includes in the neoadjuvant setting, but also when you get to the point of radiotherapy and you're looking at residual disease. And in those who've had a path CR, where there may be the opportunity to de-escalate radiotherapy, is there any evidence that it matters how much scarring you've seen in the axilla, or what the nodal burden was before, and whether that was part of the study?
Any thoughts, John?
Yeah, I think that it's clearly MDT discussion time. I think that there isn't a one-size-fits-all approach. So I don't think you can rely solely on the biology of the tumor. I think you have to combine the burden of pre-NAT disease with the post-operative results to that systemic therapy. I think you need to be meticulous in terms of the interpretation of imaging. All too often, people forget about what scans showed before the treatment even began. And so I think you really do have to go back and look again at what the burden was before the NAC started. Otherwise, you can be given a false sense of assurance on that post-operative histology result. I think that we need to be guided by the evidence. And I know today we've talked about B51. We've seen it now published in NEJM. And therefore, I think there are patients, who are triple negative, who are HER2 positive, with that N1 burden of disease that we should be considering for de-escalation. And certainly in the MDTs I go to, I think that the surgeons and medical oncologists I work with are open to that idea. And then of course, the patient, it's a long discussion in clinic to explain the nuances of it, because ultimately it's their informed consent that matters when we're doing that de-escalation. So I think it's important they're on board as well.
So I think that lots of MDTs do vary significantly in the country, John. So the MDT you're talking about, I sat on that, and they're very, very new evidence driven, which is great. But many of the other MDTs are a bit more conservative. Suzy, any comments from your point of view before we go to Michalis?
So I'd say there's been a lot of talk about this trial. It was presented 18 months ago, but it's only just been published. So that's why people have held off adopting it. I mean, it's quite compelling, but I think we have to remember it was N1 patients. Now, what did they mean by N1? They probably meant clinically N1, so mobile nodes. So I don't know. We don't quite know what nodal burden they were dealing with, but I think I would reserve it for low nodal burden. The data does not look so good for ER positive, HER2 negative. Now, we don't do that much neoadjuvant, but we do it sometimes. And I would be reluctant to omit radiotherapy in patients who've got relatively non-chemosensitive disease. I would echo with John that I think the imaging is really important. I think these patients should have optimal imaging, including a PET. And that's happening a lot in some health systems. But I think if you can't map the disease properly at the beginning, you ought to be err on the side of caution, I would say, and not omit radiotherapy. We do see patients who have a node, a sub-HEC node, a bit higher up, and we do say in our MDT, gosh, if they have a really good response to chemo, we won't do a clearance. Well, I think if you're not going to do radiotherapy, I think you need to try and clip that node and try and take it out. I don't think you can de-escalate everything all at once. But I think there are some patients who with nodal burden who've had a PASCR in breast and on their sampled node, where I think it's compelling, yeah.
I usually look also what happening in the breast, not only in the axilla, because sometimes if you have a complete radiological response in the axilla and there's still significant disease in the breast, you'll still find disease in the axilla. So you need to think before, and also depends on the biology, as we said. I know John needs to leave in the next couple of minutes. So if you have to leave, John, many thanks for all what you've done already. Now, Michalis, it's all the Greeks that are causing the problems, isn't it? It's Mamonasteri is from Athens, isn't he?
It's always the Greeks, the problem. Yeah, I agree.
Tell me, what's your thoughts about
as you said, as our colleague said, a lot of thoughts, not answers yet. I think this B51, because this is the trial we're talking about, were reluctant to use the results in the clinical practice for many reasons. One is, as already said, that the trial puts all the levels of nodal burden in the same basket. So NEO1 can be anything, clinically NEO1 can be anything. It can be one small node in a very chemosensitive cancer, or it can be 5 nodes or 4 nodes or 3 nodes in a cancer which is not very chemosensitive. And then they put in the same basket axillary clearance with sentinel node biopsy, which can be a very different, oncologically speaking, a very different technique. So we ignore the starting point. And another thing we tend to ignore or not see clearly is the difference between the subtypes. So we had this unexpected result in this trial where the triple negatives seemed to benefit from the omission of radiotherapy, while the ER positive seemed to not to benefit from the omission. So I think this makes things more complex and makes us clinicians to be reluctant to use these results in our clinical practice. As Terry said in one of the meetings we go together, we still have to wait for more time to go by and see how it will go in the future. So it's early days. This is what I want to say.
It's a trend, but it's early days, as you said, Michalis. Any other comments from your side?
Oh, I have a lot of comments. We have so many radiotherapy doctors around. So I'm if I have the go ahead, I mean, the one question I wanted to ask is, what about repeat radiotherapy on a patient who had radiotherapy in the past for breast cancer? Until recently, it was a no-no. Recurrent breast cancer, ipsilateral recurrence is mastectomy, and that was it. Do we now have the option of a second lumpectomy with radiotherapy?
Suzy, any comment?
And what factor would influence our decision? What is the factors? What are the factors?
So I mean, I think there's quite a big experience of irradiation, even in head and neck cancer, which is a much more sensitive part of the body and where much higher doses are used. But what I would say is you won't get great cosmesis. So why are you bothering to conserve the breast if you're not going to have good cosmesis? Why don't you do a mastectomy and do a reconstruction? I haven't done that much of it, but when I have done it is when patients have relapsed after mastectomy, or they've had a salvage mastectomy, and there's just kind of positive margins everywhere, and there's lymphovascular invasion everywhere, and you've got limitations on your systemic options, and you just want to kind of throw everything at it. But yeah, I mean, there's a risk of discomfort in the long term from the chest wall. I don't know if anyone's doing a second round of radiotherapy to a conserved breast. I don't. That doesn't really make sense to me.
So
No.
it's very rare that we have done it, Suzy. Most of the time it's patient driven, and the patient refuses a mastectomy.
Yeah, so and you do a lumpectomy and you just leave it at that. You give them their second line endocrine or whatever, and you tell them that they'll need very close surveillance, and if it comes back again, they'll have to have a mastectomy.
And that's where the argument is that you see, is the biology, for example, is it a small grade 1? Is it a biology that you can discuss omitting radiotherapy? If they did not have previous cancer, would you consider omitting radiotherapy? Then it might be reasonable just to do the wide local excision and omitting radiotherapy. But some people will re-irradiate if it's more than 5 years since the past radiotherapy, and there's not lots of changes in the breast, but the practices do vary quite a lot. Do you do it in Athens, Michalis?
We tend to do it more often now. I agree with Susan. The cosmetic result won't be great, but you will always get these patients who I understand that who will not
refuse
have
mastectomy. Yeah,
mastectomy. And may I add that mastectomy with reconstruction on an already irradiated breast won't be great either.
Yeah.
But yes, we increasingly get these patients who, although they're informed that this is something new, we're still in the trial period, etc. Yes, if it has been a long time since the first cancer, they are willing to have a lumpectomy and a second irradiation on the same breast.
So, Emma, you had a few other points that you wanted to mention?
Yes, I had a question actually. You caught me thinking about it. So I did have a question, and this was actually about bilateral breast cancer. I've had a couple of those recently that required bilateral radiotherapy, and I was just wondering whether the cardiac toxicity is higher, or do you treat one side and then the other, and you can still manage to keep the toxicities the same? How does that? What do you counsel the patients towards?
So the right side is no, you don't go anywhere near the heart, so it's not a problem at all. We quite often have to do bilateral breast radiotherapy, and with modern techniques, it's not a problem from a heart or a lung point of view. From a practical point of view, you end up having to treat, if you're doing breath hold on the left side, you have to do, well, we would do breath hold on both sides. We have, Michalis, are you a radiation oncologist? Sorry.
No, I'm a surgeon.
You're a surgeon. So, so I don't know if there are any other radiation oncologists who want to comment. I've had an issue recently with quite a few, with a little run of patients who on one side have needed the breast and the internal mammary treating. And when you treat the internal mammary chain on the left, you end up inevitably treating the medial part of the right breast. And I've had to do a kind of partial breast radiotherapy on the other side in those cases, because we don't actually have a bilateral breast arcing technique solution yet. We are in the process of getting one. But no, I mean, it's...
Would this be a good indication for protons, do you think, or a good scenario for protons? No. no difference.
I don't think you need it. Honestly, the number of cases who need protons. I think what you've got to realize is that protons are incredibly expensive. You know, you have to have a cyclotron, you have to produce your own isotopes on site, and decommissioning a proton unit is a nightmare. And if I don't know if there's anyone from the States here, but I know there was an abundance of proton units in the States at one point, but I think they ended up being relatively underutilized, and lots have closed.
Well, so Susan Boolbol, who was the past president of the American Society, was supposed to join, but unfortunately she had to cancel on short notice. Now, we looked at our data when I was in Aberdeen. We looked at the cardiac dose in relation to the quadrants of the breast treated and the different ways of treating it. And common sense is common. If it's lower inner quadrant, you'll have more cardiac dose. But how much does that reflect in toxicity? You can see from the literature, the cardiac doses with the new techniques have decreased significantly over years, and it's not really a major problem now. The only thing is that certain people, and correct me if I'm correct, from Suzy, certain ladies that have changes in their chest wall, if they have pectus and things like that, those are the ones that will be more challenging when you plan them, because guess what? Radiation goes in straight lines only, isn't it?
Yeah. Well, so the UK Parable study, I didn't really have time to talk about it. That's a trial that is recruiting women who are getting a moderate or high cardiac dose when they are planned with a standard technique. And the threshold cardiac dose for being eligible falls according to age and cardiac comorbidities. So if you're under the age of 35, I think, and you've got one cardiac risk factor, you're eligible if your mean heart dose is 2.4 Gray, which is still quite high. I mean, most of our patients, certainly if you're doing standard breast, it'll be less than 1, but for an internal mammary, often you will be somewhere between 2 and 3. So we are recruiting young, it's not my study, it's Charlotte Coles' and Anna Kirby's study, but we are recruiting young people who, and having a high BMI counts as a cardiac risk factor, but the other people are people who can't take a deep breath, people with pendulous breast, pectus, small lungs. I mean, anatomy varies. And you can shield the heart out of the way. You can put shielding in, but you don't want to shield the heart if you're trying to treat the whole of the chest wall or a post-mastectomy, because you're shielding your target volume, and you don't want to shield if you've got a tumor in the lower part of the breast.
And the other thing is that it's very important for us as surgeons what we put in the breast. Sometimes, correct me if I'm wrong, also, Michaelis, for example, if I do an implant, that's not a major issue. But if somebody needs to go back to theater, or if I want to put an expander, if I put an expander that has integrated port, which is a big magnet, I think Suzy will hate me if I put that. Because
well, I mean, it happens. The first time I ever saw one, our colleague Regid, he went back and changed it, but I mean, people don't go back now and change them, and basically we're resorting to old-fashioned radiotherapy because we can't get the tissue density because there's so much artifact, but it doesn't actually make patients untreatable. And we worry also about scatter and getting a cold spot underneath, so it's basically suboptimal old-fashioned radiotherapy.
It will ruin all your planning, I think. Michaelis, you want to say something?
A question. So why is it suboptimal when we use an expander with integrated valve?
Because so normally we'd be planning on a CT scan where you can see all the tissues and you can get density of all the tissues, and you can get a nice even dose because there's nothing in there that's absorbing dose and scattering dose. But when you look at a CT scan of someone who's got one of these implants in, there's this massive artifact. It's just white. So you don't really know what's happening with the tissue density there. You don't know if you've got hot spots, cold spots.
So it is a matter of planning rather than
Yes,
Planning.
I don't think it makes people untreatable, but it's not. There's a lot of uncertainties with the planning. Now, the newer planning systems have actually got some correction, and you can override what you've got on the CT scan, and you can replace the reading you're getting with a normal soft tissue reading. But I mean, there's still uncertainties.
And I know that Suzy needs to leave also in the next couple of minutes. And anyway, we need to close. Now, the next webinar is in 2 weeks' time, and it's about hereditary breast cancer. So we have Kevin Hughes from the States. And Kevin, I think, is one of the most published people in breast surgery. I think his H-score is about 60 something. He's talking about an update on hereditary breast cancer. Then we have Antonius Valaches from Sweden, from the Karolinska. He's talking about oncological consideration for gene carriers. And then we have Ramsey Carters from the UK talking about breast conserving surgery and breast surgery in general for gene carriers. And then we'll have an MDT discuss few cases. So please join us for that. Now, for now, any final comments? Emma and Michalis, any final comments? You seem very surprised, Michalis. Yeah, go on.
where are we with the polar genetic signature?
Oh, yeah, it's a good question, actually. I don't think it's moved forward. I know
No?
I've been interested in that. Yeah, so this is a profiling of the tumor to identify cases which are not going to benefit from radiotherapy. They might be high risk, but they're just not. It doesn't make any difference if you give radiotherapy. Yeah, I don't know what's happening with that. Sorry.
It's a shame because it's like an oncotype for radiotherapy.
I know.
Or...
I think part of the problem is that what do you do if you've got a high-risk patient and they've got an unresponsive profile?
Yeah.
I think I don't quite know. We haven't got anything to replace it.
Yeah.
I mean,
And any final comments, Emma, from your side, or happy?
Actually, just one final comment, and that was out of interest. What's happening or happened to interruptive radiotherapy on the basis that I worked in a centre for a bit that was recruiting into Target B, and wondered where that was going and if it's going anywhere. I certainly saw a lot of seromas that seem to stay for life.
I remember using it when I was a registrar in Guys, and I think, Michalis, you were in Guys when we were using it. That's a few moons ago, let's say.
Yeah.
I think any change on that, Suzy? I don't think that's kicked off that much.
well, okay, well, I'll tell you, there's always been a lot of skepticism amongst radiation oncologists because it's using 50 kV, which got penetration of about a couple of millimeters. So we just don't understand why you just don't diathermy out a bit more tissue from the cavity. But who knows, maybe it's some kind of weird paracrine thing. I don't know. I think we didn't have long enough follow-up from the target trial. The event rate in the target arm looked suspiciously like the event rate in the no radiotherapy arm of omission of radiotherapy trials. To me, it was about 1% per year. You need much more than 5 years follow-up. And I did do it as part of the registry study, and I was not impressed with cosmesis. I know surgeons do their wide local excisions in different ways, but I was working with a surgeon who was doing tunneled incisions, and we saw a lot of burns from the probe being too close to the skin, and I even saw a couple of cases of skin necrosis. I know there are some big proponents of it, and I know some people believe that they get very good cosmetic outcomes from it. But I mean, I think the cosmesis from external beam radiotherapy, which has so much data behind it, particularly partial breast radiotherapy, these patients who would be getting partial breast radiotherapy, I think the cosmesis is very good, and it's 5 fractions now. So.
And I think we have to close with this because we still have about 400 people online. Suzy, you need to go because you have a play to attend.
I'm going to Evita.
Enjoy that. We cannot thank you all for being with us today. So, Emma, it's lovely to have you. Suzy, it's lovely to have you, and Michalis also. And of course, we had Fady, and we had John, and Icro. And we cannot thank you also enough. Ricardo has been always with us for the translation. Akram and Mikhail Sorotos and Tatiana. It has been lovely having you all. Now, for people in the States and South America, have a lovely day. For people in Europe, have a lovely evening. For people in the Middle East and the subcontinent, have a good night, and see you in 2 weeks' time. Thank you, everyone.
Well
Thank you,
done.
Yazan.
Thank you.